This is very important topics for management of patient in ICU. How to approach practically for arrhythmia in ICU. Arrhythmia is the most common findings during patient management of the critically ill patient. So we are going to discuss about how to approach practically for diagnosis, management, and to identify the risk factor, even predisposing factor, and how to find out the ECG change in arrhythmia in ICU. First of all, the why the arrhythmia develops in patient of critically ill patient. The most common cause is hypoxia, electrolytes imbalance, metabolic derangement, infection. Other than this, there may be some cardiac based, especially the acute coronary syndrome. There may be cardiomyopathy or structural heart disease. Sometimes the medicine or medication, especially the noradrenaline or others drugs, may cause huge amount of catecholamine surge that causes arrhythmia, and also the drug interaction may also causes the arrhythmia, especially the drug which work on the QT interval, especially the macrolide and fluoroquinolone group of drugs. So what is the importance of diagnosis of arrhythmia? As arrhythmia is associated with the hemodynamics, and if the hemodynamic is unstable, that may be causes the renal impairment, ultimately AKI, and it also affect on the ventilation. If the patient is not well ventilated, if there is any patient ventilator asynchrony or patient discomfort, that may produce arrhythmia. And the arrhythmia also have the negative impact on weaning, and there may be high chance of weaning failure, especially if there is a arrhythmia. Ultimately, the arrhythmia causes end up with high mortality and morbidity in ICU. So it is very important to diagnose the arrhythmia and timely approach management of the arrhythmia. So how to diagnose arrhythmia in ICU? Number one, first of all, check the clinical condition or the diagnosis of the primary diagnosis of the patient and clinical monitoring. And the important one is 12-lead ECG. We should go for 12-lead ECG. If we find any abnormality in the rhythm, in the rate, or in the QRS complex or POF in the multi-parameter patient monitoring systems, then we should go for to check any structural heart disease or any cardiomyopathy by the point of care ultrasound, especially the point of care echocardiography or critical care echocardiography. Then we can check for the differentiation between, if there is any confusion in between the supraventricular tachycardia and tachycardia by adenosine test. Here the adenosine test is a both therapeutic and also the differentiation point for the SBT from the ventricular tachycardia. So we should evaluate the risk factor and also the predisposing factor, if there is any problem in the oxygenation and ventilation, if there any structural heart disease, or is there any acute insult of the heart, especially the acute coronary syndrome, and also the electrolytes imbalance, metabolic derangement, infection and sepsis marker, to identify the risk factor or predisposing factor for arrhythmia. Then if you this is very important, as if we can recover, or if we can treat the etiology or risk factor, then arrhythmia will be subsided spontaneously. So how to initial approach to diagnosis? This is important. If we find the ECG, then we should check the heart rate, ventricular rate, QRS complex, RR interval, and presence and morphology of the POF, and also the hemodynamic status for the management purpose. For diagnosis purpose, we should recall 4 points: the heart rate, the ventricular rate, duration of the QRS complex or structure of the QRS complex, and the RR interval, and the presence of P wave and morphology of the P wave. This 4 point is very important for diagnosis of any arrhythmia, and hemodynamically stability for the management purpose. So here, when we check or when we suspect any arrhythmia, we should check for the heart rate. Is it bradycardia, or is it tachycardia, or is it normal heart rate but there is arrhythmia? If we find bradyarrhythmia, if heart rate less than 60, the main cause may be the sinus node disease or maybe heart block. This is very simple to identify. If the tachycardia, if we find the QRS complex is white, then maybe the ventricular tachycardia, sometimes supraventricular tachycardia with heart block, but mostly if you find the QRS complex is white, mostly this is for the ventricular tachycardia. Sometimes maybe heart block, especially RBB or LBB, maybe the QRS complex is white, but that can be easily identified from the ventricular tachycardia. The challenging one is narrow complex tachycardia. So many condition of the heart may causes the narrow complex tachycardia, from normal variant, especially sinus tachycardia, to supraventricular tachycardia, or maybe WPW syndrome, or other, especially the multiple atrial tachycardia or atrial tachycardia may cause the tachyarrhythmia. So here this is simple, the bradyarrhythmia, sinus node disease, or any block in the AV node or pathway. And tachyarrhythmia, we can classify it in two groups, wide complex tachycardia and narrow complex tachycardia, for identify or for diagnosis purpose easily. So here again, according to heart rate, we can classify the arrhythmia, tachyarrhythmia, bradyarrhythmia, or normal rhythm. Then according to the QRS, narrow complex, broad complex. According to the presence of morphology of P wave, this is supraventricular or ventricular origin. Now the bradyarrhythmia, most common is heart block. In sometimes maybe there is a problem in the SO node, or sometimes maybe it may be bradyarrhythmia may be related with the medication, especially beta blocker or rate limiting calcium channel blocker, or sometimes in case of traumatic brain injury there may be a raised ICP that causes bradyarrhythmia. So what are the type of heart block? We can easily find out from the ECG. There may be first degree heart block, second degree, or third degree. Whatever it, we should remind for practical purpose the third degree and Mobis type 2 second degree heart degree block usually needs treatment, otherwise don't need any treatment. So if we find the heart rate is less than 40, we can easily suspect that may be a third degree heart block. So what we do in the bedside, we will approach by the giving intravenous atropine or intravenous isoprenaline, then go for the temporary pacemaker, then permanent pacemaker with collaboration with the cardiologist. And what are the tachyarrhythmia in ICU? So for identifying, we have told earlier that we should focus on 4 points. What is the heart rate, and what is the morphology of the QRS? Is it narrow or broad? Is there any regularity of the RR interval, or presence of morphology of the P wave? If the wide complex, then the differential is very low, supraventricular tachycardia with the heart block, or ventricular tachycardia. If it narrow complex tachycardia with irregular RR wave and P is absent, that is simple, that is atrial fibrillation. If narrow complex tachycardia, narrow complex but regular, and P is absent, that is supraventricular tachycardia. So when we find narrow complex tachycardia but P absent, then differential is 2, either supraventricular tachycardia or atrial fibrillation tachycardia. If rhythm is irregular, then atrial fibrillation. If rhythm is regular, then it is supraventricular tachycardia. If P is present, then we should go for, is it sinus? Is it sinus tachycardia when PR interval all are normal, but only the tachycardia, that is sinus tachycardia. If it is PR is short, this slide is very important for diagnosis of any tachyarrhythmia. I repeat again, especially for the narrow complex tachycardia. Narrow complex tachycardia, P wave is absent, regular, then we should suspect supraventricular tachycardia. Narrow complex tachycardia, P absent but irregular, then it is atrial fibrillation. Narrow complex tachycardia, P is present, then we should check for the morphology on P and PR interval. If P wave and PR interval is normal, then it is sinus tachycardia. If PR interval is short and there is a slurred QRS, then we should focus for WPW syndrome. If P is abnormal in shape, then we should check all the P wave. If more than 3 P wave abnormality in term of morphology, then it is multiple atrial tachycardia. If it uniform, then it is called atrial tachycardia. So it is very important slide for tachyarrhythmia diagnosis. So tachyarrhythmia broad, it is classified as focal atrial tachycardia or multiple atrial tachycardia, atrial flutter, atrial fibrillation, AVRT, sorry, WPW syndrome, AVNRT, ventricular tachycardia, and when it is maybe sustained or non-sustained, maybe monomorphic or maybe polymorphic. So how to diagnose supraventricular tachycardia if with evidence from the ventricular tachycardia? If any confusion for differentiation from supraventricular tachycardia or ventricular tachycardia, please treat the patient as a ventricular tachycardia, as ventricular tachycardia is more grave, more dangerous than the supraventricular tachycardia. So, but there is some clue, there may be some clue in the ECG that may indicate that is called ventricular tachycardia. We can easily remember by remembering from the mnemonic A, B, C, D, E, F that I have taken from the Life in the Fast Lane website. Sometimes there may be history of myocardial infarction, and there may be structural heart disease, and even the supraventricular tachycardia usually don't have any structural heart disease, but ventricular tachycardia usually have structural heart disease or recent MI or old ischemic heart disease. There may be in case of ventricular tachycardia, there may be axis deviation, broad complex QRS, concordance, there may be positive concordance, there may be negative concordance. Dissociation, there is no association from the POF and QRS complex, that is called the atrioventricular dissociation, and the early part of the QRS complex is very slow and it is more than 40 seconds. There may be fusion bit, capture bit. So A, B, C, D, E, F, all the point favors the ventricular tachycardia from the supraventricular tachycardia. So the ECG change, the ventricular tachycardia, this is chest lead from B1 to B6, that is positive concordance, all the wave are positively spiked, and here all the wave are negatively spiked, that is favored for the ventricular tachycardia. Here the early part of the QRS complex. This is more rapid and more perpendicular, and here it is the early part of the QRS complex is more slow and slurred. There is maybe a like a projection, but here the almost up. So this is supraventricular tachycardia with aberrancy. There is a M pattern, there is block, supraventricular with block. That's why the QRS complex is a bit wide. And here this is truly ventricular tachycardia. And here that is in between the ventricular beat, there is some fusion beat when the normal beat fused with the ventricular beat, and sometimes there may be if there is a normal beat coming from the SA node, that may be captured in the normal beat, but there is no fusion beat or capture beat in case of any supraventricular tachycardia. That is more pathognomic for the ventricular tachycardia. So how to manage supraventricular tachycardia in ICU? So in case of supraventricular tachycardia, atrial fibrillation is most common. So for management purpose, we have to know the duration of the atrial fibrillation. If it less than 48 hours, then it is defined as a new atrial fibrillation, then can be treated by the DC cardioversion if it present with hemodynamically instability or compromise. And then we should focus for the any offending agent or any risk factor, especially any drugs or any electrolytes imbalance or any infection or any sepsis. Then also focus for the reversible factor. If still AF is present, then we should go for either beta blocker or rate limiting calcium channel blocker. If there any effect of the problem with the beta blocker or calcium channel blocker, we can go for the amiodarone. And we can also give for the rhythm control, if there is any no structural heart disease, then we can go for also the flecainide. If there is structural heart disease, then we can give amiodarone for the management of the atrial fibrillation. So here the treatment option, what we should focus on: rate control, rhythm control, anticoagulation, and also the correction of the underlying causes. This is the pure supraventricular tachycardia, that is also called the reentrant tachycardia. Here the narrow complex tachycardia with absent P wave, and it is almost rapid onset, usually don't have any structural heart disease. But I have told earlier, the ventricular tachycardia usually have the structural heart disease, and the supraventricular tachycardia is usually common in women. Here this is the rhythm lead. The heart rate is more than 100. There is no visible P wave. So this is narrow complex tachycardia, regular and no P wave. So it is supraventricular tachycardia. If the beat or irregular, then we can check for the atrial fibrillation. Here the supraventricular tachycardia in the form of WPW syndrome. Here the atrioventricular reentrant tachycardia or pre-excitation, when the impulse don't go through the normal pathway, then the impulse is go from the SA node to AV node very fast, then causes the pre-excitation. Then the pre-excitation produce delta wave like abnormality. So here the P is almost near to the QRS complex, that is the PR interval is very short, and the QRS complex is one type of slat that is called the delta wave. So some important tips here: we should not prescribe calcium channel blocker, beta blocker, digoxin in case of WPW syndrome. And whatever the rhythm, if there is a hemodynamic unstable, or that means if there is a arrhythmia with shock, then we should go for decardioversion for any kind of rhythm abnormality, except for the atrial fibrillation if it is more than 48 hours. But we can, in that case, we can give the chemical cardioversion. But if hemodynamically stable, we can go for the chemical cardioversion like sotalol, amiodarone, or flecainide, procainamide. The ultimate and the most important things for the WPW syndrome, go for the electrophysiological study for the evaluation of the abnormal pathway. Then ultimate treatment is, or gold standard treatment is, radiofrequency ablation. Here the multiple atrial tachycardia. The P is different morphology or morphological pattern. So that's why it is called the multiple atrial tachycardia. So what is the important tips for the regarding narrow-complex management? For the narrow-complex tachycardia management, we should check for the regularity and irregularity. If irregular, then atrial fibrillation or flutter or multiple atrial tachycardia. Or if there is a regular, then we should go for check for the any WPW syndrome or any sinus tachycardia or any the pure supraventricular tachycardia. If the supraventricular tachycardia, we should check for or we should check for any responsibility from the vagal maneuver or adenosine. If no, then we should go for check for others like the amiodarone, and also give also check for is there any in the form of ventricular tachycardia, if it confused with the ventricular tachycardia. And if it WPW syndrome, that may require electrophysiological study and radiofrequency ablation. Ventricular tachycardia may be sometimes associated with various type of channelopathy, especially the long QT syndrome, Brugada syndrome, catecholaminergic polymorphic ventricular tachycardia, and electrolytes imbalance, of course, hypoglycemia, hypothermia, electrolyte imbalance. All type of electrolytes may causes arrhythmia, especially potassium, hypokalemia or hyperkalemia, hypomagnesemia or hypermagnesemia, hypercalcemia, hypocalcemia, except for sodium. Sodium is less likely to produce any arrhythmia. So ventricular tachycardia can be categorized as ventricular tachycardia with hemodynamics stable, ventricular tachycardia with unstable or compromised hemodynamics, ventricular tachycardia with pulse, ventricular tachycardia without pulse. For the management purpose, then it can be categorized. If ventricular tachycardia with unstable, then we can go for the cardioversion, decardioversion. Ventricular tachycardia without pulse, this is the one form of the cardiac arrest, so we should go for the cardiac defibrillation. BT with unstable, then we can go for the cardioversion. BT without pulse, if we suspect cardiac arrest, then we should go for defibrillation. This is the regular white complex QRS, but no visible P wave, and this is ventricular tachycardia. Ventricular tachycardia may be uniform, that is called sustained, and monoformic. All the wave are same. This is polymorphic. Here the QRS complex is high amplitude, here is low, here again high, here again low. That is or screw like, or that is also called the torsades pointes, polymorphic ventricular tachycardia or torsades pointes, that may be end up with ventricular fibrillation, that is very dangerous than the monomorphic BT. And here the ventricular fibrillation, here the QRS complex is white, there is no P wave but irregular, that is ventricular fibrillation, that is very dangerous, very dangerous. So how to manage ventricular tachycardia? If clinically stable, then we should check for any airway breathing circulation problem, we should go for the chemical cardioversion or medicine management by the medicine amiodarone sotalol. Cardioversion, if needed cardioversion, then we should go for we should do after giving proper sedation. If there is any electrolytes imbalance, especially long QT or torsades pointers, should consider magnesium infusion. If it is compromised with hemodynamics or BT with shock, then we should go for first of all the airway breathing circulation. At the same time we should manage with the DC shock or cardioversion. And if there is any need of any pacemaker, then we should go for also the pacemaker supplement. That is the pulseless BT, which is one of the cause of or one of the form of cardiac arrest. Then we should approach according to the ACLS protocol, immediate unsynchronized defibrillation, as there is no time for synchronization, but some defibrillator machine have the option for synchronized. Then we can give synchronized defibrillation. And first of all, we should start with CPR with minimal interruption, 3:2. Then check for, first of all, the cap. We can remember by the cap. First of circulation, then airway, then ventilation. IV access, then adrenaline, 1 milligram after every 3 to 5 minutes. After giving three times of DC shock, if there is no revert, then we go for the amiodarone 300 milligram. And side by side, we should explore the reversible cause of 5H 5Ts. In ICU, most common cause of arrhythmia are infection, electrolytes abnormalities, medication, ischemia, anemia, hypoxia, change in volume status, and hemodynamics. Tachycardia is more common than the bradycardia, and most common cause of bradycardia includes beta blocker and also the different type of heart block. If patient is less likely remain hemodynamically stable with higher degree of AV block, usually require temporary pacing, ultimately the permanent pacing if the heart block is persist. The majority of the atrial tachycardia are due to the atrial fibrillation, atrial flutter, AV NRT, ectopic atrial tachycardia, rapid ventricular rate, and underlying pre-excitation with the atrial arrhythmia. For hemodynamically unstable or symptomatic patient, AVNART or SBT tachycardia, initial choice is adenosine or cardiac DC cardia version. And if it is met, underlying pulmonary disease is the most common cause, especially the COPD. AF is most common in critically ill patient in ICU. So first of all, should check for the etiology or any risk factor behind the atrial fibrillation. Then we should go for the rate or rhythm control and anticoagulation, and ultimately if there is any rhythm problem is more than the rate control, then we should go for the chemical cardioversion. If it is come within 48 hours, we can give the DC cardioversion. Indication of the urgent cardioversion in AF, that is the hypotension or shock, especially the hypotension or shock. And in case of all arrhythmia, if it is come with the shock, then therapy of choice is DC cardioversion. Torsades pointers and other form of polymorphic BT, rapid ventricular rhythm are associated with hemodynamic instability and predisposing to degenerate to a BF. So monomorphic BT complicated with polymorphic BT. Polymorphic BT is complicated to torsades pointers, ultimately ventricular fibrillation. And ventricular fibrillation and pulseless BT are two common form of cardiac arrest, and that requires emergency defibrillations. So thank you all for patient sharing.